We're here at OVBC 2020, and we have the pleasure of talking to Dr. Sigman, one of the leading experts in opioid-free surgery, and has a really great perspective on a number of advances and innovations. So thank you for spending some time with us.
Oh, it's my pleasure. Thanks for having me.
Tell us a little bit about your practice's evolution towards opioid-free surgery. I think there's a lot of interest nationally, but very few people have figured out how to do it well.
Yeah, I mean, it's interesting. We all got caught up in this society of pain within our medical education, and we just sort of were told we're going to use opioids. They're not very addictive. They're inexpensive, and that's sort of what we all sort of got schnookered into, is sort of the expression I like to say. And so it's been a difficult time sort of breaking that culture, which is really what we've been trying to do. I've been on this trail now for about 7 years.
Okay.
We were one of the earliest adopters of liposomal bupivacaine in particular. Our hospital was very generous. The C-suite in particular, we were really we were very hard hit with the opioid epidemic, and so they recognized that they were willing to spend money on the front side, which is the argument against opioid alternatives.
That's right.
And so we started using it in the inpatient setting, and the results were so really quite profound that I then pushed it into the outpatient setting as well. And I mean, the good news is when I first started giving these talks, we could barely fill a room, and now it seems to be one of the most important topics that people are willing to listen to.
There's a wait list now. Yeah. What were some of the big challenges, both on the patient side and on the provider side? Just kind of specifically thinking, there had to be a time when patients were like, whoa, no opioids, no pain medicine? I don't know if I'm in for this.
I think communication was always paramount.
Okay.
And explaining to the patient that it's not that we're just not going to give you pain medication, it's just that you're not going to need it. So when you have that conversation, what I found in particular is that just about every patient knows someone that has succumbed to the opioid crisis and epidemic. So even having the conversation with the patient was sort of a relief that we're going to address this for you. We're going to take care of your pain, and we're going to manage that for you, and we're going to make sure you don't need these opioids because they're so addictive. As far as the paradigm shift for the provider, it's not easy to change, decades of process. And so some doctors were early adopters and believers, and many weren't. There was the cost issue associated with opioid alternatives, where the argument is, yes, opioid alternatives are more expensive, but how expensive are opioids to our society as a whole?
That's right.
Loss of life, the cost of managing substance use disorder, our firefighters and EMTs and Narcan and all of the loss of productivity at work, all of those things really play into the overall cost of the epidemic.
Yeah, fascinating. Tell us a little bit, even just anecdotal or kind of like personal narrative. What were some of the struggles or some of the times when it didn't go well in the beginning, and then kind of the evolution to get to where you guys have kind of a protocol or a pathway now? Yeah,
that's a great question. It took us about 6 months to get to the point where we knew the right mix, because in particular with liposomal bupivacaine, it acts much more like a medical device than it does a pharma product. In other words, you have to have the right volume, and you have to be able to touch every nerve that's been injured in the process of the surgical intervention.
Okay.
So even though you're admixing, you're not diluting, you're just spreading the medication to more spots. And that took us a while. So we were getting mixed results at first, and it was a little disconcerting. My partner, Dr. Dave Perbilla, who's an arthroplasty surgeon, and we took the lead on this. And within 6 months, we figured it out. It was actually quite gratifying, because the ultimate study that was done to prove that liposomal bupivacaine does work basically was our mixture.
That's awesome.
So it was very gratifying to know that we had a play into that, and now it's awesome to be able to really help patients that I'll never meet. Convincing doctors that this is something we need to do for society. And the other thing that's quite interesting, I say to the laggers, the doctors that are, well, maybe we're going to do it, maybe we won't. I said, look, the most liberating thing you can do in clinical practice is to become an opioid-sparing surgeon. I said, before this, 7 years ago, I was an orthopedic surgeon, but I was a pain management specialist.
That's right.
So I had to manage pain. I was writing refills on prescriptions. I was having to wean patients off. We had angry patients who were on the no medication list and all of these things. But now, we don't write refills. As a matter of fact, for many patients, they don't need opioids at all. And so it's liberating.
Yeah.
You don't have that issue anymore. I can sleep well at night knowing that I'm not going to get calls at 3 in the morning from the emergency room from an irate
I'm incredibly
patient.
jealous already just talking about this, thinking through my inbox with my refill request right now.
Yeah.
What are some kind of new innovations or changes that are coming down the pipeline or that are already here that you kind of have integrated into your practice or that you see has promise?
Great question. So there's really two things that have been the most pivotal for me right now, I would say within the last year and a half to 2 years. First is that liposomal bupivacaine became an on-label use for a regional block in the upper extremity.
Okay.
So what that has now transitioned, rotator cuff surgery, which was one of the most painful surgeries that you could undergo, where as many as even 10 to 12% of patients were on long-term opioids because of their surgery, are now opioid-free. They go through a 2 to 3 day window where they have minimal pain, don't require opioids. It's really completely transitioned rotator cuff, as well as even total shoulder replacements now can be done as an outpatient.
Wow.
Really phenomenal. And the second is a newer technique called iovera, which is a liquid nitrous oxide. And what we do is we actually freeze the cutaneous nerves.
Yeah, I've heard about this.
Yeah. So we do this about 5 to 7 days before surgery. It's the anterior femoral cutaneous nerve and the infrapatellar branch of the saphenous nerve. And it's remarkable. You do that block 5 to 7 days in advance of surgery. We then do a liposomal bupivacaine, either adductor block or a localized block. And patients are off all medication within 5 days for a total knee replacement.
That's incredible. Is that coupled with an intra-articular injection as well?
Yeah, so we'll do the intra-articular liposomal bupivacaine. It's a field block that we'll do. So Vindasa down in New Orleans is a big proponent, near Evamine here in California. So we've validated this now, and it's really transitioned total knee replacement to a new paradigm as well.
Wow, incredible.
Yeah.
Well, thank you so much for spending a little bit of time with us. Looking forward to your talk later this afternoon. Everybody tune in and consider the Value-Based Care Conference next year.
#follow the fro.